of Health Informatics with Ami Banerjee, and in TRE specifically, I work on CCU003 project on direct and indirect effects of COVID-19. And today I'm going to talk about the validation of a previous study that Ami, Laura, and the team worked last year in March 2020. And this was based on a simple model before the first lockdown. And the main parameters was the baseline risk of mortality, of comorbidities, of chronic diseases. And two main parameters was the relative risk of death of COVID, all-cause mortality 1 year, a relative risk, and infection rate of COVID-19 as determined by lockdown and social distancing policies. Now, I'm just going to show quickly two slides about this previous model, and I'm going to call that prediction model. And what we did in TRE was to validate the study on TRE data and look at how this model applies on TRE data. So the diseases and comorbidities that were used in the prediction study was CVD, CKD, diabetes, being on corticosteroid, age over 70, and body mass index. But for simplicity of the plots, I'm going to show you the plots with number of comorbidities, 0, 1, 2, or 3, and more. And this study was based on CPRD data of about 3.8 million people of age 30 and over, and based on these comorbidities, and the caliber phenotyping was used to identify these diseases. And I'm going to show you the model, but this is a projected number of excess deaths based in CPRD data. And here you see two different scenarios based on infection rate of 10%, or just mitigation, and different values of relative risk. And what you see here is the number of excess death, and the color shows the mortality risk, 1 year mortality risk. And if we don't do nothing and 80% of infection rate, naturally the number of deaths would go higher. So at that time, the values of RR, IR were not known. So it was just based on scenarios of different values, of maximum of 3 for relative risk and different values for infection rate. So this is the models, like the mathematical representation. So here it's just a very linear relationship between excess death and total number of deaths, which is the sum of excess death and background death. And it's based on relative risk and infection rate. And here is just a 3D representation of how the proportion of excess death to total death changes. And here you can see the contour plot of the same plot. And for example, for an RR of 2 and IR of, let's say, 0.5 or 50%, you would expect a proportion of around 35% to 40% of the total death to be the excess death of COVID. So this was just scenario-based of different values of RR and IR. Now for validating of this model in TRE, we use the data in TRE for England. The data was provided in May 2021. We used age 30 and over, and after applying lots of quality control on data, there are tons of things, you might not believe it, but there are lots of records even with birth dates larger than death dates, but well, we had to deal with that. So we ended up with 44.9 million number of people. There were two limitations, main limitation that might have affected the study is that the birth is just year, and since we have death in days, that might have affected this. And also the medication data was just available from 2018. As for phenotyping for COVID-19, we use the definition of CCU0013 project, work of Spiros, Johan, and Chris, and we use different definitions of caliber available in TRE, and also extended that with Caliber portal. For CKD, we use another customized phenotyping in CCU003, and For corticosteroid, we use dispensed medication. Again, since we have only 2018 data, this is not a historical use of corticosteroid. Now here is the study design. So the prediction study based on CPRD, the baseline date of the cohort, and cohort entry was the latest of GP registration date and age 30 and over. And the prevalent of underlying conditions with at least 1 year of follow-up were looked at this point. And the exit death is death or the end of the study, which was 1 January 2017. So here we have a younger population. To validate this, the simplest thing would be, it is a cohort, retrospective cohort study. The simplest thing would be to have the case and control groups during the pandemic and compare them to find the actual relative risk and infection rate. But the problem here is that the non-COVID cohort here also includes indirect effects, deaths affected indirectly by COVID pandemic. So we used 2 other study designs, and I'm going to show you the result based on the second one, and the third one will come in the paper, and you will see that in due course. So here the case is again between 1 March 2020 and 1 March 2021, and the control group is from pre-pandemic, from 1 March 2018 and 1 March 2019. And the baseline date for both cohorts for prevalence of diseases is 1 March 2018. And here we have used kind of divided the population into 2 random subsamples and cross-validated these to make sure that the age is handled properly. So based on the real and observed values of COVID death in TRE, we realized that the relative risk of 1-year mortality is way higher than 3. So it was around 5.59. And infection rate, the observed value was lower than what we expected. It's 4.88. There are 2 reasons. The previous study was at the start of the pandemic, and also here we don't have all of the COVID positive results. It's just based on, I think, pillar 1 and 2, and also we don't have asymptomatic results in TRE. So probably 4.88 for an infection rate is an underestimation. So what we did in this study is that we found a pre-pandemic baseline mortality in a control group, and we applied that model of a previous year's model with observed relative risk and infection rate and compared that to actual values. So here we saw that with actual values of infection rate and relative risk, the proportion of excess rate to total death is around 18%. And here we can see 3 different heat maps stratified by age, and here is a number of baseline characteristic, baseline conditions. This is based on CPRD data scaled up to England. This is based on what we predicted and applied the model on control cohort pre-pandemic, and this is observed values, which is really just KM estimate, Kaplan-Meier estimates was very close to observed values. So you can see that values are quite similar and close to each other. One important issue is probably just the overestimation of age related to observed values and underestimation of other values. And this age is definitely a confounding factor, and this is going to be discussed in the alternative cross-validated design that I showed you. So the detailed design of this and other pyramid style, more intuitive plots will be in the paper, and I will share that with you. So in conclusion, what we're going to discuss in paper and in this study is that national data can definitely be used to estimate baseline and COVID-19 mortality. Now, for non-communicable diseases, at the start of the pandemic, we don't have case fatality rate, R0, and other parameters that are used on dynamic infectious disease models. But here, this is the first study that has used the baseline and background death of chronic diseases as a parameter in a model for infectious disease. And also, we also think that this model needs to be validated. So any model that in CPRD or data needs to be validated in larger data sets such as TRE, and also in different settings and different countries. Now, as I said, the paper will be shared with the whole consortium in due course. Sorry, that's my timer. And also the code will be internally available to consortium on GitLab repository. And after the publication of the paper will be available open source on GitHub. And there are codes also available for phenotype extraction and cohort generation. And that will be shared on GitHub, and you can use that in TRE. Thank you very much also for all the colleagues in TRE and in the consortium that helped me from different projects. And I really enjoyed that. Thank you very much, Kathy. And yeah, I'll be glad to get any questions and comments. And Ami, if you are here, please feel free to jump in for any comments.